Great. Thanks, Mady, and thanks for all of you who've decided to stick it out until the bitter end here. So my worst iliac complication actually is bad for unusual reasons. One is in whom it occurred, and secondly, for when it occurred. So this came to my mind when I started thinking about iliac complications. I've had plenty of clots and dissections and retroperitoneal hematomas, but none of them were in a very good friend of my sister. So this is somebody that my sister was on a first-name basis with. They got together frequently for coffee. And she was also on the cardiac transplant list. So we were taking care of her for that, and my partner and I had been assessing her and anticipated that she would probably need an intra-aortic balloon pump. And so as we were taking care of her in the setting of an occluded left external iliac artery, even though she really didn't have disabling symptoms, the thought was she could really use an arterial conduit. And so in light of that, the external iliac artery occlusion was treated. So here you can see at the top of the screen a large common iliac artery that's in good shape, flowing contiguously into the internal iliac artery, and then just a small stump of the external iliac artery. So really not an unusual case in any way. So the lesion was crossed and dilated and stented, as I think just about anybody on the panel up here could easily do. And then after that, the first post-procedural angiogram shows dye just pouring into the pelvis. And so now we have what has gone from an elective case and kind of a marginal indication for the procedure in the first place to clearly a life-threatening bleed, just dumping blood into the pelvis. So when that happens, what do you do? Well, what anybody would do under those circumstances. We initially had our appropriate response. But when that happens, I think there are two steps that always have to take place. And these really go without saying, but the first is to not panic. And I think that for most experienced operators, that's a given, but it still amazes me how occasionally I'll be in a lab where there will be somebody with relatively low levels of experience, and something happens that is clearly going to kill the patient. And that is no time to panic. You still have to kind of be an Iceman at that point in time and think through, okay, what are my options at this point? And the other thing, when you blow a hole in an artery, the first thing that from a fellow level on up that you obviously have to know to do by reflex is just stick the same balloon into it that caused the problem and stop the exsanguination. That at least gives you enough time to take a breath, think about it, and decide what to do. So I mentioned that there were two things that were unique about this case. One was in whom it occurred, and the second was what was the time frame for this. So I want to kind of set the stage of what was not available. First of all, obviously, if this patient is being considered for a heart transplant, she is clearly end stage in cardiac condition. She's not going to tolerate general anesthesia, major vascular procedure. Even if the vascular procedure were undertaken successfully, she'd never come off the anesthetic. She'd never wake up. So unless she got a new heart at the same time that she got her arterial repair, we couldn't afford to do anything. So surgical repair was off the table. But this also happened a long time ago, and I think anybody in this room right now who saw this complication the decision wouldn't be what type of treatment to use, it'd just be what size of covered stent to use. So in this case, though, this was before the days of the Viabon or Fluency or even the wall graft. It was clearly before the days of the iCast or the VBX. So we did not have that as an option. And so we have to consider then what is an option for this patient with a big hole in her external iliac artery. Surgery is not an option, and you don't have a covered stent available. And as crazy as this sounds, there are hospitals in the U.S. right now that don't stock things like covered stents in which percutaneous interventions are performed. And I'm sure many of our overseas colleagues also have the same experience. So I just ask you to think for a minute, what would you do? You've now got a hole in an external iliac artery in a non-surgical patient. What can you do? So one option would be to say, well, let's just get back to where we started. If you had coils or some other way to embolize or occlude the external iliac artery, at least you can stop that bleeding. You could put a balloon in upstream. You could even shoot clot into that vessel, anything that would stop. The alternative is to just let her bleed out on the table. You obviously can't let the balloon in forever. So even though a lot of whats were not available, there was a who was available. This was when Julio Palmaz was still in practice. And I had heard Julio give a talk on hand making a covered stent. So I called Julio up. The patient's on the table. The balloon is occluding the vessel. And fortunately, he was available in San Antonio. I called him up and I said, Julio, I know you gave this talk not too long ago about how to make a covered stent. Could you kind of walk me through that? So he says, I'll fax you the instructions. So he faxed the instructions to the cath lab. We went up to the operating room, got the equipment, and while the patient is still on the table, we made this thing. So what you use is Impra graft material. It's PTFE graft material, non-reinforced, and it's balloon expandable. You can essentially triple the diameter of the graft material with a balloon. And then it has to be sewn onto a balloon expandable stent. It has to use a special type of suture. You can't use a cutting needle or it'll shred the Impra, so you have to use a 6/0 suture with a non-cutting needle and sew it to a stent. But then this thing is so bulky that you need a 10 French sheath to put it in, and you actually have to kind of devise a pusher that you place on the shaft of the balloon to shove this thing in. And the final product looks like this. We actually did a dry run, made sure that we could actually construct this, expand it, and that it would work while the patient's still in the cath lab. It worked, so we prepared one. We went contralateral, and you can see the balloon at the top of the screen, which has now come in from the contralateral side, occluding inflow so that she doesn't bleed out while we're putting this in. And then from ipsilateral, we forced this stent graft in that we'd constructed by hand. You can see that the contrast is still sitting in the pelvis, but there's no additional bleeding at this point. Inflated it to high pressure. Fortunately, the balloon didn't rupture. The PTFE yielded and expanded, and we actually had a complete seal of the vessel. And the patient not only survived, she went on to get her cardiac transplant. She still remained a good friend of my sister for many years, and so it did have kind of a happy ending. So Teresa mentioned an ounce of prevention is really crucial. I think if there's ever a good time for an ounce of prevention, it's with an external iliac artery. If you're ever going to rupture an artery, it's going to be an external iliac in an old female with a chronic occlusion in a small vessel, and it's going to be calcified. She had everything except age and calcification. When you hear patients complain of pain during balloon expansion, that's the time to quit. And it's also good to recognize that it's okay to have a 50% residual. You can always come in and treat a restenosis. It's a whole lot easier than treating a ruptured vessel. So I thought you might enjoy that case. Thanks.
Mark, that was phenomenal, and wow, what can I say? You guys are talented. Was that a common practice? Like, how did you know how to do that? I mean, that's just to suture the thing. That's just taking it to a different level.
So this was one of the things where it was in the early days of intervention, and I just happened to be at a conference just like this. I think one of the values of a conference like this is sometimes you get an idea for that one case that may make a huge difference for the patient. And afterwards, actually, Gary and Ansel and I used to teach courses down at the global headquarters for Cordis down in Cincinnati, and we actually printed up the instructions on how to do this, and everybody who went through that course got those instructions because this was before the days of commercially available stent grafts.
Can you have about a minute, can you give some tips about now? Like, what do you suggest for we have a lot of fellows, a lot of folks that are young and they're just going to practice. What are some of the few tools that you think they should have for aortoiliac situations like this?
Yeah, that's a great question. I think, and part of my practice now is in a small community hospital where cost consciousness is very important. We don't do very many cases. We can't afford to have things expire on the shelf. But I think you always have to be prepared for dehiscence of a common iliac artery from the aorta, or perhaps even an aortic rupture. So I think you have to have a compliant large diameter balloon, some commercially available aortic occlusion balloon. Then at least you can stabilize the patient and transfer them to another hospital. And then even though the Viabonds are fairly pricey, they average around $3,500, I think you kind of have to have those on the shelf because you don't want to be in a situation like this and for lack of a few $1,000s, you're put in a situation where you could lose a patient. So I think those are kind of the most important two things to bail you out of a dangerous situation.
I think those are great points, and I would just add one thing, and also know the sheet sizes that you need. That's why a lot of folks advocate 7 French, for aortoiliac intervention. I think we have kind of moved away from that to some degree because we have the 018 Viabonds now that come in decent sizes. But also understanding the sheet sizes is very helpful because sometimes the device you want to put doesn't fit. Like you said, you had to use 12 French, you said, for that device.
Yeah, that's right.
Okay, great. Thank you very much.
Question.
Right.
How were you able to elongate that to introduce it into the system once you put the PTFE over the stent?
How were we able to do it?
How you
introduce
crimped it?
it.
How did you crimp it?
Oh, so you just take at this time, the stent that was available was the in-stent, or intra-stent rather, which had smooth edges, and then you sew it, and then you crimp it. We hand crimped it. On those days, it was an Opta 5 balloon, 5 French. And you just crimp it down. We were used to doing everything by hand during those times, which actually I think is still a good skill to have because occasionally you'll be doing a case even now in a low inventory lab and you'll have the right stent, but the shaft is too short. And I think everybody needs to know how to strip it off, expand it a little bit, maybe with a dilator from a sheath, just enough to get it onto a different balloon, hand crimp it, and then you have to be very, very careful as you introduce it through the hemostatic valve that it doesn't get scraped off. So you can do that by pinching the back end, kind of pushing it in, being very careful, checking it under fluoroscopy to make sure that it's still on the balloon while it's in the sheath, never crossing a difficult lesion with the stent, always cross with the sheath and then advance the stent and back the sheath out. So they're still valuable skills. It kind of reminds me of in the vascular surgery world where the open surgery used to be what everybody did and nobody did endo, and now it's flipped around. It's kind of like nobody knows how to hand mount stents or protect stents, and it's sometimes life-saving.
Well, thank you very much. For the sake of time, we're going to move forward. Please have a safe trip back home.